First, we're going to start with Dr. David Herrmann, who leads the CMT clinic at the University of Rochester. He is the leader of a major study that will measure outcomes of potential therapies, and he has been integral in developing important tools that measure the progression of CMT, and ultimately, these tools will measure how drugs will slow, stop, or even reverse CMT's progression. Welcome, Dr. Herrmann.
Thank you for inviting me to speak today on the topic of preparing for clinical trials in CMT. By way of background, we conduct clinical trials in 4 phases. Phase 1 studies involve a small number of individuals and are aimed to determine the appropriate dose and safety. Phase 2 trials are larger and again focus on evaluating safety of interventions, but also provide indicators of whether a treatment might be effective. But before a treatment can be approved by the FDA, generally phase 3 trials need to be conducted. These involve more affected individuals and again confirm safety and specifically the effectiveness or efficacy of a treatment. Once a treatment is approved by the FDA, there may be further studies after the marketing of the drug, and these are known as phase 4 studies. In order to determine whether a treatment is effective for any condition, the FDA guidance is that it should have a clinically meaningful effect. Specifically, the FDA advises that a potential therapy should improve how patients feel or how they function before they can be approved. The modern era of treatment development for CMT began with the conduct of trials of ascorbic acid, otherwise known as vitamin C, across the globe. There were multiple studies of ascorbic acid, including one that was conducted in the United States and that we were involved in. This was a double-blind placebo-controlled trial that ran for 24 months. And what all the trials concluded was that vitamin C was ineffective for CMT1A. But we learned much from the trials in terms of how best to design future research studies and clinical trials in CMT1A, and also that the way we measure the effects of treatment in trials was not adequate. Specifically in the CMT1A vitamin C trials, we used an outcome assessment known as the Charcot-Marie-Tooth neuropathy score to measure whether vitamin C was working. But what we learned was that even in the 2-year trial, those treated with placebo did not show any significant change in the CMTNS scale over the 2-year period. In other words, the Charcot-Marie-Tooth neuropathy score was not sensitive enough to pick up change among individuals with CMT1A. During the vitamin C trials, we formed a consortium known as the INC, or Inherited Neuropathies Consortium. This is led by Dr. Michael Shai out of Iowa, and there are currently over 20 centers around the world who are involved collectively in developing treatments for different forms of CMT. Importantly, however, before we can successfully conduct treatment trials in CMT, it is important to be ready for those trials and to have the methods to assess whether treatments are working. And we know that a key approach in developing treatments for CMT will be to intervene before individuals develop severe disability. And that means eventually treating children and conducting trials in children. And at the time of the ascorbic acid trials, which were conducted in adults, we had no assessment tool for children with CMT. So the Inherited Neuropathies Consortium, led by Dr. Joshua Burns out of Sydney, developed a tool called the Charcot-Marie-Tooth Disease Pediatric Scale. It is a functional assessment, and the items are displayed here. And we have shown that this can pick up change in CMT1A and other forms of CMT. And when trials conducted in children, this is likely to be the way we measure whether treatments are effective. But we know that CMT may sometimes begin at birth or in the first year of life, whereas the CMT pediatric scale is only appropriate for children over the age of 3. And therefore, the Inherited Neuropathies Consortium, in work led by Joshua Burns again and Melissa Mandarakis, developed a CMT infant scale. The items are shown here, and it focuses, like the CMT pediatric scale, on age-appropriate assessments of function and developmental milestones. But what about adults? The CMT1A study was conducted in adults, and as mentioned earlier, the Charcot-Marie-Tooth neuropathy score was shown not to be able to pick up change in sufficient periods of time that are feasible for clinical trials. A big gap in our trial readiness for CMT1A and other forms of CMT was the lack of a measure to determine the function of adults with CMT. So in work led by University of Rochester, we developed a scale known as the CMT Functional Outcome Measure, similar to the CMT Pediatric Scale. It measures hand function in different ways. It provides measures of lower limb strength, balance, and different assessments of mobility. And we are now studying this in longitudinal studies to determine how sensitive it is to pick up small changes in function in individuals with CMT over time. What is also important is the patient's perspective and the perspective of individuals in terms of how the CMT is impacting their well-being. And we did not have any specific scale for CMT at the time of the CMT neuropathy, at the time of the ascorbic acid trials. And so we subsequently have developed a scale known as the CMT Health Index, or CMT High. Not surprisingly, when we obtained input from individuals with CMT, we learned that the key areas of challenge include mobility limitations, foot and ankle weakness, inability to do activities, hand and finger weakness, among many others. And so we now have a CMT Health Index that we are using in longitudinal studies and in clinical trials. And this should allow us to obtain the patient's perspective during future clinical trials on whether treatments are working or not. You may have heard the term biomarkers. Biomarkers are a different way to potentially assess the impact of treatments in clinical trials. The measures and assessments I've discussed previously are all clinical outcome assessments. Biomarkers are markers in blood, other fluids, or tissue that indicate the state of a condition, and they can be used to see how well the body's responding to a treatment. And why they're important in the setting of a slowly progressive condition such as CMT is that they may show an earlier indicator that a treatment is working before an individual notices improvement in symptoms or before a physician can detect improvements on the clinical exam. And there are different types of biomarkers, all of which we in the Inherited Neuropathies Consortium have been working on. There are biomarkers in blood that we can assess. We can take biopsies such as skin biopsies. Importantly, we can use imaging procedures such as MRI of leg muscles and a technique such as named confocal microscopy of nerve endings in the skin. These are the Meissner corpuscle touch pressure receptors, which we can image and visualize in the skin. And we can also use electrical methods such as nerve conduction studies, or have individuals wear sensors on their body to obtain information around physical activity and other aspects of function. And all of these are under study within the Inherited Neuropathies Consortium. A few years ago, we in the Inherited Neuropathies Consortium obtained NIH support to conduct a study known as Accelerate Clinical Trials in CMT, or ACT-CMT. And this study has the goal of improving the way we conduct clinical trials for CMT in the hopes that we can detect treatment effects in future trials, and it addresses gaps in our outcome measure tools and our biomarkers for future clinical trials. In the CMT study, we are assessing whether the CMT functional outcome measure can detect change in individuals with CMT1A over a 2 to 3 year period. We're also evaluating whether MRI of calf and thigh muscles can detect change in CMT1A over 1 to 2 years. We have previously shown in small studies that this is a very promising technique, but we're now assessing it across 5 different centers. And we're also evaluating this technique called reflectance confocal microscopy of touch nerve endings in the skin called Meissner corpuscles, shown here, to determine whether it might be a sensitive way to measure the sensory aspects of CMT1A for future clinical trials. In addition, through studies of the Inherited Neuropathies Consortium, we are assessing wearable sensors, and these are of different types. We're looking at a sensor called the actigraph, which can be worn at home and assesses one's physical activity. For example, an individual may have a clinical visit and then wear an actigraph at home around their waist for 7 days, and we can obtain wireless information about the number of steps taken during that time and time spent doing different levels of physical activity and time spent sitting and sleeping, for example. We can also use wearable sensors to measure gait and balance at clinical visits, as shown here. The APDM system is worn at different sites on the body, and we can analyze gait and balance very precisely during walking tasks and balance tasks, and obtain information such as the length of one step, step speed, and the amount of sway with balance activities. We're hopeful that these wearable sensor measures will provide sensitive indicators in future clinical trials as to whether treatments may be effective or not. I have spoken and focused mainly on CMT1A, and that's where most of the clinical trial readiness work has occurred to date. However, we're conducting similar studies in CMT1B, CMT2A, and CMTX, and rarer forms of CMT through the Inherited Neuropathies Consortium. And if you've not participated in CMT, there are numerous ongoing studies that are being done through the Inherited Neuropathies Consortium, and you could explore these at the following URL. Thank you very much for your attention.